Um, Representative Jaspers, I know that you have another place to be. We've got enough for a quorum. So if you want to go ahead and start your bill, I would invite you to do that. What is that, number one? See if you're on.
Yeah, witness
Yeah,
one.
okay.
Thank you, sir. Okay, thank you, committee. Thank you, Chairman. I bring before you House Bill 546 LC 339496S. Mr. Chairman, committee, I like bringing pharmacy bills. I guess it's my third or fourth one in the past number of years. My late father, Don Jaspers, was a pharmacist. And, back then they called him Doc Jaspers, and I stood kind of in memory of him. But what you have before you is a pretty simple bill. It's the Pharmacy Adaptation Bill. Key things, it's not to change a physician's treatment plan or expand the scope of practice. I know all of us breathed a sigh of relief right then. But it is to help a patient, not to delay drug therapy and decrease the workload at a pharmacy. House Bill 546 will allow pharmacists to use their professional judgment to adapt prescriptions for small things or changes, which, if not done, would delay patient care. In the bill, you'll see we're in the Georgia Pharmacy Practice Act. Line 28, you'll see what is allowable, the change or adapt if the quantity or package size is not commercially available. And an example of that is a cream size may be unavailable and allows to adapt what they have on hand. Also change a tablet to a capsule if not available. On 31 is the change in quantity is related to the dosage form and strength. An example for this is a patient receives a prescription in an emergency room or an emergency clinic for an antibiotic, say 500 milligrams for 14. Due to drug shortage or unavailability of the 500, it will allow the use of a 250 and then prescribe 28 of them. That's the idea. Pretty easy. On line 33, having a 90-day maintenance program is the way it's going now. This will allow adaptation to be done so the course of medicine can be done. We'll note that this does not include Schedule 2, 3, 4, 5 treatments. On line 35, we're talking about synchronizing a drug therapy program in the maintenance world to the 90-day. Will allow the addition of medication to sync their 90-day order. Example, 10 days may be added to that to create that example for the synchronization. And lastly, in line 43, I know this has been on your mind, they've got to document the adaptation to the patient's record, and they must obtain consent from the patient. And they also cannot do this if the prescriber indicates by order that the adaptation is not permitted, which can happen occasionally, I'm sure. That's the bill, and it's hopefully I explained it well, Mr. Chairman.
I think you did very well. Any questions? I know this was would have been helpful to me when I practiced.
Yes, sir.
Seeing no questions, do I hear a motion? Second?
Second.
All those in favor of?
Aye.
Say aye.
Aye.
All those opposed? Congratulations.
Thank you, Mr. Chairman.
Bill.
Thank you for letting me go first.
Oh, you're welcome.
On to Ways and Means.
All right. Chairwoman Sharon Cooper, would you like to come up?
And Mr. Chairman, is it all right if Melissa comes with me? Because
Yes.
my father wasn't a pharmacist.
Yeah.
And just in case it's a pharmacy bill, which I have not carried before, so I might need some help. Where'd Melissa go? There we go. Okay. Okay. I'm bringing for you today House Bill 1072. This is a bill very dear and near to my heart. If you will remember, in 2017, we passed a law which allowed us to partner, or to go to a not-for-profit group and for them to establish a pharmacy that would help Georgians across the state that had no insurance, could not afford their medications, and would be able to get those medications from reclaimed drugs that otherwise would have been destroyed, and to help them with their medications. And I think everybody should be proud. Since 2017, our Georgia's Donated Drug Repository Program, which is what this is called, has filled over, are you ready? 796,000 prescriptions for Georgians across our state. Most of these going out not at the $64 million that they would normally have costed, $64 million, but at a rate of about $6 for a 90-day supply of medicines. This is helping poor people all over the state of Georgia. They have grown so much that they've had to move twice to bigger facilities, even though this is only mail order and people do not walk into this pharmacy. They still needed much bigger room to work. So what the bill does, okay, it shall make it where drug reverse distributors shall make diligent effort to donate their surplus eligible medicines, and therefore any entity shall be allowed to donate surplus eligible medicines. Today, medicines that are often eligible for reuse are often destroyed. And so that expands our ability to have to get those medicines. Part 4, it clarifies the donation of medicines for the program, that it's not considered wholesaling. Not like that. Part 5, it says that participating pharmacies that are only operating pursuant to the program do not need to follow comprehensive pharmacy formula requirements. And I think that means they don't have to keep specific drugs on hand all the time, because they only have what is donated to them. And this, for the public, is called goodpill.org. I have tried to talk about it from the well over and over again, hoping that everybody would put this out on their websites for people to know about. And when you go to goodpill.org, there's a list of the medicines that they have in stock. And if they have the medicine that a person needs, all it takes to get it is to have their doctor send the prescription there to that pharmacy, or to have it transferred from a pharmacy. And what they do, in case they only have a certain amount of drug, they know how many people they have using that drug. And then if they can't put new people on it, they won't put new people on it until more drugs are available. Let's see, what else do we which drugs we have? Okay. Section 6 allows eligible recipients more flexible substitutions for the similar drugs. You just heard it in the bill before us. In other words, if this pharmacy does not have the pills, but they have a capsule, then they are allowed to exchange that. Or if they need to have it, they don't have a 500, but they have plenty of 250s, they're allowed to say, okay, they'll give them two 250s. So they're allowed that flexibility. Also, if we get any big settlement on drugs, like over the opioids, they would be eligible to receive a portion of that, however it's divided up, because I think we have a big settlement coming fairly soon. It doesn't say they have to, but it says they would be eligible to. And they are tax-free. One of the other things that also, really the main thing they did, they needed more help. And so they're allowed 2 more pharmacy technicians. And now it's 4-to-1 ratio.
Well, 4-to-1.
4-to-1.
If, as long as 2 are certified, and these would be for non-dispensing duties because of all the drugs that come in, they need to sort.
And the processing. It's much more complicated than just a pharmacy and how they get these drugs. And that is what this bill does. But it really helps goodpill.org. And we are only one of 2 states in the country that has this program, and we were number 1. So we can be proud of it and what you voted for.
Yeah.
Pardon?
Nice to be number 1.
Number 3. Because there's only 2 states that have it.
Oh, right.
It's a joke.
Okay. I'm
Talk
just glad they
slower.
won.
Nice to be number one anyway. Are there any questions from the committee? Okay, is there anyone, we didn't get a sign-up sheet out quick enough. Is there anyone that wants to speak to this? No. Oh, okay. Who's got? Representative Douglas.
I have one question. The gist behind the bill, I love it. But how do you get these drugs in? I mean, from people who turn them in, or how do the drugs get to the plant other than mail in? I mean, who's sending the drugs to you to
I think the
reuse?
wholesalers make every effort, and the reverse distributors, which are companies that go in and help pharmacies and hospitals with their returns on almost expired drugs.
Right.
Okay. And so they're not coming from the general public, correct?
No.
No.
Okay, okay.
I mean, the public would like it. In fact, we started talking about this because a gentleman brought it years ago before 7. In fact, he brought it in 2015 because his wife had died and he had all of her medicines. A lot of it basically hadn't been opened, and he thought that was terrible. And we put this bill, a similar bill, into effect in 2015. And it was, our department was supposed to set up this pharmacy. And for 2 years, they did nothing. So we had to go in and rescind that bill in 2017 and put it with a nonprofit.
Okay.
And they have done yeoman's work and an excellent job. If you can imagine, almost 800,000 prescriptions filled, worth $64 million that they'd been filled at a pharmacy.
Thank you. Good, Bill.
Any other questions? Hearing none, do I hear a motion? Second? All those in favor? All those opposed? Hearing none. Chairman Cooper, you have House Bill 1072 passes.
Thank you very much. And thank you to the committee and to all of you for the original bill and for passing this, the people of Georgia. Thank you.
Okay. I think you're gonna take some time. Okay, Senator Merritt, this here SB 76.
All right. Good afternoon, members.
Good afternoon.
I had to run up here. We're still voting downstairs. We're still in session, but the debate is very long. Thank you, Mr. Chairman, for and members for hearing this bill today. We did hear, or you all heard this bill last year. We didn't quite get it over in time. So I'm here again today, but basically this SB 76 is a insulin cap bill. It is the cap insulin cost for state employees. Me coming from a insulin dependent family myself, and knowing the importance and concerned about the rising insulin costs, I thought this legislation was important, and so that we can extend it to our state employees and some of them are our members, you know, between both chambers. I myself, I'm right on the cusp. I'm already kind of predetermined, but, you know, hopefully I won't have to ever be dependent on insulin myself, but want to make sure that we are able to cover some of our state employees. It does couple, y'all just passed a bill for glucose monitors. I think it came out of your chamber maybe 2 weeks ago. So this is just an extension of what I'm trying to do. But this program, the cost of it is very low. You should have the fiscal note there. 1 year would cost the state about $306,000. That'll cover approximately 2,400 members of the state health benefit plan. And this would include self-insured and direct coverage plans under the state health benefit plans. Roughly right now there are 665,000 people who are dependent on our state health benefit plan, and 60%, roughly 3,800 are insulin dependent that are on the state health benefit plan right now. So this 38 38,000 are insulin dependent on the state health benefit plan. So basically it's an easy bill. We just want to cap that cost, and we have the two options. You can get the 30-day supply, and I think we added an amendment to give a 90-day supply. So open to questions, but I am asking for your favorable vote today.
Okay, are there any questions? Anyone? Oh, okay. Representative Kelly.
Thank you, Mr. Chairman. Senator, thank you for bringing the legislation. This is limited only to the state health benefit plan.
Yes.
Was there a reason why you limited it just to the state health benefit plan versus private health plans as well?
This is just merely for our state employees. It wouldn't include any private plans.
Do you see merit in maybe including the private plans?
I'd be happy to. As many people as we could extend it to. And, I know that we have had some manufacturers lower their insulin cost price, but again, they are businesses. They can change that price at any moment. Versus if we can kind of get this into law, we can get it permanent for workers.
Thank you.
Thank you.
Any other questions?
I just want to thank you for bringing this. This is something I had a while ago, so thank you very much. I'm fully in support of this, so thank you for getting
Thanks,
this
Representative.
across the finish line.
Thank you.
Representative Douglas, is that you?
At the appropriate time, Mr. Chair.
Okay, now's a good time. Let me ask this. Anyone here to speak to the bill, since we didn't have a sign up? Seeing none, you're on.
Do pass.
Second, all those in favor say aye.
Aye.
All those opposed? Congratulations, Senator.
Thank
Senate
you.
Bill 76 passes.
And who will be carrying, or would you carry it, Mr. Chairman?
Yes, I will help. I will carry it for you.
Thank you. Awesome.
All
Thank
right,
you. Thank you all.
You're welcome. Yeah.
Thank you all.
Senator Williams, I don't believe is here. So that brings us to House Bill 745, Representative Kelly. You can address from there if you want, or you can go to the end, wherever you want. All right. Like I said, I hope they don't miss you and hit me.
Thank you, Mr. Chairman, members of the committee. I bring before you House Bill 745, which seeks to improve patient outcomes and safety by ensuring adequate nurse staffing levels and promoting transparency and accountability within our healthcare system. This will be done, Mr. Chairman, by establishing some clear guidelines and reporting mechanisms under the bill, many of which are already being implemented. We're really trying to just encompass some of the best practices already taking place. It aims to address concerns related to nurse staffing and ultimately enhance the quality of healthcare delivery through our healthcare system. I would also say that we've heard this year a lot of talk in terms of workforce and having individuals that want to enter the workforce in a variety of fields, but one area we've certainly seen a shortage throughout our healthcare systems in the nursing space. And one of the paramount reasons for why I brought the legislation was that I felt it's something that can be done, implemented easily. Many of our health systems are already implementing many of the things in the bills, but this would, statutorily define and put in place some guardrails that could be used ultimately, I think, to help not only deliver better patient outcomes, but also improve the morale in our nursing community and hopefully make Georgia an even more attractive place for nurses to come and work and provide health care in our healthcare system. The key provisions, it does make clear that hospitals will adopt a written nurse services staffing plan. It does that working in conjunction by establishing a nurse staffing committee. Once that's done, then there will be some reporting requirements to the Department of Community Health. And also just makes clear that individuals who report a lack thereof of staffing or maybe not adequate levels are protected from retaliation. Finally, it establishes a advisory commission composed of 9 members, 3 appointed by the governor, 3 appointed by the president of the Senate, and 3 appointed by the Speaker of the House, that will help provide expertise and guidance, and ultimately make some recommendations to us through a report every year, Mr. Chairman. I'll be glad to answer any questions regarding legislation, but I know we have several groups from both the Nurses Association and the Hospital Association who are going to ask to speak to the measure as well.
Any questions from the committee? Okay, I know that I have. Oh, I'm sorry, Representative Maziak.
Thank you. Thank you, Mr. Chairman. Chairman Kelly, you said they will report to us yearly? Is
Ye-
that what I heard you say?
Yes, so starting at line 160, it talks about the advisory commission shall submit to the Speaker of the House of Representatives, the President of the Senate, the chairpersons of the House Committee on Health and Senate Health and Human Services Committee, and make available to the public a report that includes recommendations for further legislative action, if any, in order to improve working conditions and quality of care in hospitals pursuant to the intent of this article.
Thank you.
Thank you. Appreciate the question.
Representative Stinson?
Yes,
Did
sir.
you?
Yes, sir. Thank you, Mr. Chairman. Friendly question, Representative Kelly.
Certainly yield for that.
Yes. If I recall, haven't we had legislation in the past relating to addressing nursing shortages? And if so, I mean, we still, what's going to be different with your bill compared to what we had in the past?
I know that there's been an ongoing conversation just
Okay.
in general about workforce.
Gotcha.
And I do believe, in agreement with you that there have been, there's no silver bullet, I think, when it comes to addressing the shortfall of nurses or other workers in our workforce. And it takes multiple approaches. And so this was one that really says, look, we want to help facilitate conversations inside the workspace
Mhm.
so that everyone feels like their voice is being heard, so that we can sit around the table and have those conversations. I think in many of your health systems, this kind of conversation is taking place in one way or the other.
Mhm.
But for those that it's not, we're saying, hey, why don't you give it a shot? And let's try this approach and see if the conversation between the administration side and the nursing side working together will ultimately improve morale. And we know people that are happy at work seem to deliver better results.
Mhm.
And that's what we're looking to facilitate here, is ultimately by improving the morale, by attracting more nurses, that we're going to improve the patient outcomes.
Okay, very good. Well, thank you for that. I just curious about it because I know that has been a big topic lately about the nurses shortage across the state. And we're so happy that we have universities like Port Valley State University now that has a nursing program. So for any of those in the room that's interested in going to school to pursue a career in nursing, that may be something they want to consider. When you agree, Mr. Representative?
Hey, I think having the opportunity at Fort Valley State is a great opportunity. And I know you've worked diligently on that effort, and I appreciate you for doing so.
Representative Douglas.
Yes, sir. Thank you, Mr. Chairman. To my friend and Chairman also, I have a quick question for you. Is this like an oversight committee for the hospitals or for the nursing in hospitals?
What the nurse staffing committee would do is meet together and make recommendations to the hospital that they would use them for consideration for staffing. And when they do so, then it just asks for the hospital then to develop a nurse staffing plan where they at least consider the recommendations of that committee. Doesn't bind them. It just says consider them.
Okay. Further question?
Yes, sir.
Is this at every hospital?
Yes.
Okay. Thank you.
Mr. Chairman, one last word.
Yes.
I
of course.
just want to know if there's anyone in the room here representing Department of Community Health. If so, I need to get your information afterwards because I really need to speak to you.
I'm going to recognize them. I ain't forgotten, but thank you. Okay, any other questions? Okay, we have some people here to speak to the bill. First, I want to call Anna Adams, Georgia Hospital Association.
Members of the committee, I'm Anna Adams with the Georgia Hospital Association. We represent 145 hospitals in the state of Georgia, ranging in size from small rural all the way up to large urban. We are proud to have worked with Representative Kelly on this legislation. Part of the issue, I think, with the lack of workforce or the workforce shortage doesn't just include recruitment, but it also includes retention. And I think this bill is a step toward making sure that those nurses that we have within the hospital setting have a voice when it comes to staffing. One of the things that we learned during the pandemic that I think kind of became more public knowledge is that we have to remain flexible as hospitals. And so while this bill does not create mandatory staffing ratios, which we very much appreciate, it does give nurses the opportunity to weigh in on what it looks like from a staff nurse perspective when they're providing care, not just in one department, but from an ICU perspective, a cardio perspective, med surg, you name it. Each different department within the hospital is going to have different staffing needs. And so this gives them a voice and it gives them the opportunity to weigh in with hospital leadership as we develop our staffing plans. Those staffing plans are already required at the state level. So this is really just a different approach to making sure that we have that buy-in from our staff. So we are, again, excited to be at the table, happy to continue working on this issue. We want to make sure our nurses feel supported, and I'm happy to answer any questions that you all may have.
Yes, Mr. Chairman. Thank you, Mr. Chairman. I just want to, thank Anna and the hospital associations for working with us here and recognizing what the goal is and what the goal wasn't. And I appreciate your partnership. And I know we've talked, I should have said at my initial presentation, we've worked together and going to have a couple amendments that ultimately, if we get a motion to move forward, that we'd ask the body to consider and to help stay with the goal that we've stated without encroaching in an inappropriate way on our healthcare providers. So appreciate
We appreciate
that.
Representative Corbin?
No, I think it's me.
Oh, okay, go ahead. I'm sorry.
At the appropriate time, I'll offer a due pass.
Well, we've got
For-
some more questions. We got some more.
Oh, I'm
questions, but
sorry. I
Thank you,
thought
though.
we were-
Thank you.
Thank you for your enthusiasm.
Representative Sharper.
Thank you, Chairman. Just quickly, any one of you guys can answer this, but when you're looking at the nurses as a whole, are you looking at the RNs, the LPNs, CNAs, everybody? When you're looking at the total shortage, because also I see where, have some nurses, their job duties are kind of heavy, and you have people like the CMAs and nurse techs, and people can lighten some of the things that they have to do. So I just wonder if y'all just looking at everybody.
I can speak to the structure of the nurse staffing committee and how that was made up. That starts in line 67, the OCGA 31-732. So you see on line 68, it talks about requiring it. Line 70, it talks about should we compose of members who are representative of the types of nursing services? So kind of a broad definition there. And then starting on line 72, it says that the CNO, the chief nursing officer, shall be a voting member. It says also on line 73 that at least 50% of the committee shall be registered nurses who, one, provide direct patient care at least 50% of their work time, two, are selected by their peers. But there's also some language that we're going to have maybe to change that verbiage for you. But yes, our goal is to include the spectrum across, and we're gonna have some people from the Nurses Association here with us today too, speaking, that may can address that for you even further. But thank you for the question.
All right,
If
thank
I
you.
could add to that, current staffing plans within hospitals are considerate of the different levels of service that you might need for each different department. Some require more intensive care, and so those would be RN and higher level providers, while others may just require kind of a stay and recover, which would be more of an LPN. So the staffing plans are currently considerate of that.
Okay. Seeing no other questions, I'd like to call forward Brandy Sylvan with DCH.
Thank you, Mr. Chairman. Brandy Sylvan, I'm the Director of Government Relations with the Department of Community Health. We're definitely supportive of the intent of this legislation. I do want to just share with y'all, though, that we're evaluating whether or not there would be any fiscal impact on our survey activity, because currently we do survey hospitals on behalf of CMS, which is a federal entity. So they provide the funding for those staff. So if we were to receive a complaint about a violation of the state statute, that would require some state funding for that activity. So I guess I'm not sharing any concerns necessarily, but letting y'all know we are looking at if there would be a fiscal impact or if we might be able to change the language about the investigation so that there wouldn't be, so that it could fall under our current process.
And Mr. Chairman, I'll say that I appreciate the work DCH is doing and committed to, if we see there's a fiscal impact, working with you and the commissioner to try and address that as needed as we move through the process. So thank y'all for what you do.
Yes, sir. I'll be happy to connect with you on that.
Okay, thank you. Any questions? Tim Davis from the Georgia Nursing Association.
Thank you, Chair. My name is Tim Davis. I'm the Senior Director of Government Affairs of the Georgia Nurses Association. Certainly grateful to Representative Kelly for sponsoring this legislation for us. And really what it is a culmination of a collaborative effort over about 3 years. During the 2022 off season, we approached the Georgia Hospital Association with an idea of representing nurses in this way, having a shared governance model that wasn't cookie cutter, to be applied to all health systems across the state via a ratio mandate, but something that gives nurses buy-in and a seat at the table to be able to, have their grievances addressed, to make recommendations to the health system about how best to deploy the nurses that they already have. You all already know that the state of Georgia is facing a nursing shortage. And as the state looks at ways to infuse more nurses into the pipeline, this is another tool that will help and aid in us retaining the nurses that we have year over year. And so we appreciate the work of everybody to get it to where it is right now, and would humbly ask for your favorable consideration at the appropriate time. I'm happy to take any questions that you might have.
Thank you. Are there any questions? You have no questions.
Thank you.
All right, thank you very much. Okay, we're to a point, we do have 2 amendments, but let's go ahead and hear a motion to move the bill first. I hear a motion. Second. Okay. Let's address, and that LC on this bill is LC 339495. House Bill 745. We have the First Amendment, 33-2051. Representative Kelly, would you like to speak to First Amendment, or would you like the folks out there?
I'll be glad to, Mr. Chairman. You'll see the amendment says we're striking lines 21 through 23 and replacing it with the verbiage on 3 through 6. But the important part really is you're not really striking anything 21 through 23 in essence. You're really just adding going to line 23 at the end, where it's after authority. It says provided, however, that this shall not include a state-owned or state-operated hospital.
Okay. Any questions on the amendment?
And I would make that as a motion.
Do I hear a motion? Second. All those in favor say aye. All those opposed? First Amendment passes. We have a Second Amendment, 33-2052.
Thank you, Mr. Chairman. Amendment 33-2052 speaks to the makeup of the members who are on the nursing services, nurse staff committee. And we were trying to just be a little more broad and flexible when we talk about who's going to serve there. So we would replace lines 75 and 76 and replace with represent different inpatient care units, such as, but not limited to, medical, surgical, intensive care, and cardiac. I think the goal is largely the same. I just think this verbiage says it in a more concise and direct way. So I would offer that as the amendment.
Go ahead, Representative Sharper.
I know it says such as, but not limited to, medical, surgical, intensive care, cardiac. Just keep in mind, may want to consider emergency as well, because you have a lot of burnout sometime in emergency ER rooms. So those nurses. So.
Okay. Good comment. This amendment was actually brought by the Georgia Hospital Association, and they're here, so they'll consider your comment for sure.
And I think the language where it says, but not limited to, I think would address that.
Right. Any other questions? Hearing none, do I hear a motion?
Do pass an amendment.
Okay, we're talking about amendment 33-2052. Second? All those in favor say aye. All those opposed? The amendment passes. Now we're back to the main bill. LC 33-9495. Do I hear a motion? Do I hear a second? All those in favor say aye. All those opposed? Congratulations. You have Senate Bill, House Bill 745 is passed.
Thank you, Mr. Chairman. I appreciate yours and the committee's thoughtful consideration.
Okay, I see that Senator Williams Senator Williams has entered the room. Would you like to come up and speak to Senate Bill 348, SB 348/FA?
Thank you, committee. We've been working with funeral directors and the Composite Medical Board and others on the issue of death certificates in the state of Georgia. This is a very simple bill. And there's only one change from what the code is, and it's on second page, line 37. If an individual has not been seen by a physician within, and it's changing from 180 days to 60 days. What this means is if a medical examiner or coroner answers a call and finds someone who has died, if they have been seen by their regular family physician within the last 6 months, then they're refusing to take the case and to investigate the death. A lot can happen to someone in 6 months. So that's why we're moving it to 60 days. A lot of you know I had a heart attack back in November, but I saw my regular physician in June. So that was 5 months. And if I had died from that heart attack, the medical examiner or coroner could have kicked my death certificate back to my regular family physician. And when he checked me, my EKG was normal, my blood pressure was normal. He did blood work, my cholesterol, everything was fine. So he would not have had a clue what had happened to me. So this is just kind of closing the gap where the medical examiner or coroner cannot refuse to investigate someone's death if they have been seen past the 60 days. Be glad to answer any questions. I hope I've been clear with my explanation.
You have been very clear. No questions or comments? I thought we would have at least one.
Thank you, Mr. Chairman. Thank you, Mr. Chairman. Thank you, Senator Williams, for your work on this legislation. You know, of course, I do support. And just to add to what Chairman Williams has stated in his presentation, this also helps with families being able to get death certificates in a more faster manner so they can take care of business of their loved one that passed away. There's been some times where the coroner or the medical examiner gets into this back and forth with the physician who's going to sign off on the death certificate, and it leaves the families in a limbo trying to get that death certificate so they can move forward on getting business taken care of. So whatever we can do to help families across the state, I would certainly appreciate it. So thank you for your work on this legislation.
Lobbyist Travis Lindley and his group here in the room, they have sat in and helped us. We have been meeting with the Composite Medical Board and others. Matter of fact, I received a call from the Composite Medical Board just a few minutes ago wanting me to meet with them to discuss this issue. It has been an issue for quite some time, and we've been working, trying to get this resolved for families. But thank you for your comments.
Thank you, Mr. Chairman. Senator, I appreciate the bill. I think it's a good bill. My question is, will this cut down on autopsies or?
No, not really. Autopsies are only ordered in certain situations. Here in Georgia, you only have, I think, 5 medical examiner offices, and they're in the metro areas. So they have their own doctors, and this is what the medical examiner is. And that's Gwinnett, Fulton, DeKalb, and Cobb. I'm not sure if Clayton has a medical examiner or not. All of the other counties, the 154 counties throughout Georgia, they rely on the GBI to do autopsies on questionable deaths. And a lot of times the GBI will investigate and look at medical history and look at medical records. And it's very difficult because they're so overwhelmed and so short-staffed a lot of times to even get an autopsy performed. There is one doctor in Cordele, Dr. Latham, that does private autopsies. And matter of fact, our funeral home was carrying someone down there today because the coroner's office, GBI, refused to do an autopsy on a 61-year-old person who just dropped dead. So the family is wanting to know what caused the death. So, you know, we've got to get more funding and more pathologists to the GBI so that they will perform more autopsies, because it's, you know, these families deserve to know, and they deserve answers when their loved one passes away.
Okay, but, your example of yourself made me think that this might cut down on autopsies, which is why.
Well,
'Cause it would be an unexplained death.
mine would have been an unexplained death. What I had was 98% blockage in my widowmaker. And so I had to have a heart cath and a stent. But there's nothing to show for that. You know, the number one symptom of a heart attack is sudden death. So when somebody, and that's when, yeah, the doctors usually are just making an educated guess. And that's more than likely what would have been put on my death certificate was a heart attack. Death certificates are not legal documents. Death certificates are scientific documents. And this is a lot of confusion to a lot of people. And you have doctors that are hesitant to sign death certificates because they think they can be sued over it. I don't know of any situation where any doctor's ever been sued over a death certificate on the wrong cause of death that's been put.
Thank you.
Thank you for the question.
Thank you, Mr. Chairman. To my friend, thank you for bringing the bill. My only question, does this affect a patient that's on hospice in any way? I know sometimes you can be on hospice anywhere from a month to 2 years or longer.
No,
And they're not under a doctor's care during that time.
Whenever you go under hospice, then you become a patient of the physician that's with hospice. So this would not affect them at all. No, sir.
Any other questions?
That's what I was gonna say.
Oh, okay, Second. All those in favor say aye. All those opposed? Congratulations, Senator Williams. Senate Bill 348 just passed.
Thank you, sir. Thank you, committee. Thank
All right, we have a little bit of information coming, if y'all can give us just a few minutes. We've got, we're gonna have on the screen here in a few minutes, the ASGE, they want to speak to a issue that we have here, in the state of Georgia. And it's going to be, Don Palmisano, sorry, Donald. Are you on there now?
Yes, sir, I am. How are you
Is
doing?
Don on?
Thank you, ma'am.
Which,
I appreciate all your help.
okay. Don, can you hear me, Donald?
Yes, sir. How are you doing, Mr. Chairman? Can you hear me?
We cannot hear you. Can you hear us?
I can hear
Donald's
you.
got a beard now. Oh. Hmm?
Oh, can you hear me now? Oh, can you hear me now?
Yeah,
Oh, perfect. Well, good. Hello, Mr. Chairman. How are you doing?
go ahead.
Oh, perfect. All right. Yes. First of all, thank you, Mr. Chairman and members of the committee. Really appreciate the time. And this really is just an update. My name is Donald Palmisano. I'm the Chief Executive Officer for the American Society for Gastrointestinal Endoscopy. I used to be the CEO for the Medical Association of Georgia until I took this role in 2021. I still do have ties to Atlanta. My wife's law practice is actually based in Atlanta, so she flies back once a month, and I also come back to Atlanta on occasion. So this is really just an update from the summit that we had over the summer. Currently, ASGE, we are working in 2 states, Maryland and Georgia, on a project designed to increase the follow-up for colonoscopy rates for uninsured and underinsured for those patients that have an abnormal colorectal cancer screening test, which is usually about 50 to 70% of those patients. As you may know, the American Cancer Society's latest report said that CRC is now the leading cause of cancer death in men under 50, and the second leading cause of cancer death in women who are also under 50. So right now, we're in phase 2 of our project. Phase 1 was during the summer where we had the summit in Atlanta. Phase 2 is that we're now working to gather the data so that we can have some hard data to have some further discussions with members of the legislature. We're in phase 2. We're working with community healthcare systems to administer our project in Georgia. CHCS, they're a federally qualified health center that cares for patients in about 14 counties in middle Georgia. CHCS, they will ID and assist hundreds of uninsured and underinsured patients get screened for colonoscopy using a stool-based DNA test. So they will also support the patients with navigators to guide them through the full continuum of care. So the patients will receive a screening through a stool-based test and then a colonoscopy if they so need it at no cost. We anticipate starting the actual screening of the patients in April or May. The idea is that we're going to use some de-identified project data to ultimately develop a roadmap and model public policy to use across the United States. The overall goal, because these projects have been done before, is to develop a sustainable source of state funding to ensure that people who have these abnormal colorectal cancer screening tests are able to get care who don't qualify for public assistance on Medicaid so that they have access to timely follow-up care. So in this process, we're working with key stakeholders, physicians, allied health professionals, navigators, legislators, regulators, across the whole continuum advocacy organizations to really get this project moving. The overall goal, again, is to find some sort of solution that we can implement across the country. And we are working in full disclosure with a number of groups, which include Exact Sciences, think of Cologuard, the little blue box, Ironwood Pharmaceuticals, and Braintree, who are all funding this project so that patients won't receive any cost at this point. So with that, I'm more than happy to take any questions.
Thank you, Donald. Donald Palmisano. I always have trouble with your last name, and I apologize, although I've known you for many years.
No problem.
Any questions? Okay. I've got a statement to make. I think this is very important. I had a good friend, an oral surgeon, who was president of the Dental Association about 3 years ahead of me, that died of colon cancer. He waited a little too late, and I can tell you this is a disease that if there's a delay, the results are not good. And it's something that needs to be picked up very early. And this is a good approach. I like this approach. And hopefully we'll be working on this for you and your organization.
Thank you.
With that, yeah, go ahead, Donald.
I just want to say
ahead,
thank
Donald.
you very much. We appreciate that.
Oh, you're welcome. With that, this committee is at a close. Thank you, sir, for all coming.
All right. Thank you.